there were lots of twists and turns along the way, but there were certain things that I was always interested in. And I'd say the number one thing that I was always interested in was really evaluation. So like my very first bodywork experience was having a Rolfing session sometime in the mid 70s or late 70s, somewhere around there. And I had this initial really strong feeling that it was amazing that someone could look at someone and touch them and really know a lot about their body. I thought that was just kind of amazing. And so from that initial impression, I thought, if I get involved with this bodywork thing, I want to be a rolfer. I didn't really have a lot of variety of exposure. So I received more of that kind of work a few years later when I moved to Seattle, where bodywork happens. And then when I went to massage school, I really was thinking, oh, I'm just going to get this out of the way and then I'm going to go be a rolfer. But fate did not work out that way. I liked doing massage, I realized. I really liked it. And it, in some ways, I think I kind of remember, I think maybe I like this deep tissue massage, like maybe at least as much as I liked Rolfing, you know. And there was that initial sort of delicious effect where you're getting worked on a lot for the first time and it's like everything feels good. It's all good. It's all so good. And then not long after I graduated from massage school, I met Ben Benjamin. And so there was this whole thing. I had no idea that there were all these other kinds of evaluation. And the idea of linking, like a person comes in and says, my elbow hurts, and you say, well, I can figure out what's wrong with your elbow, and then I can help you with that. That was like intoxicating. Like, wow. And so I was totally excited about learning that and doing that, and I did. I got pretty good at doing that kind of work that in many ways is like treatment massage. Like, that's kind of what they call that. And but I still wanted to do structural integration. I don't think they called it structural integration back then. They just called it Rolfing. And as it turned out, I did the Hellerwork training in the late 80s, I guess. Yeah, late 80s. And it wasn't the right time or the right training or something for me. I felt like I was looking, I know if nothing else, I was looking for something that was more assessment driven. And I had sort of had the impression that it was going to feel more assessment driven than it really was when I learned it. And I was like, oh, it's kind of more like a routine. And I was starting to realize I'm a guy who doesn't like routines. It took me a while to really get that. So I kept studying more stuff. About this time I started teaching at a massage school. I think I kind of muddled along for a while, for a couple, 3 years. And then somebody showed me a videotape and a manual by this guy named Rich Fay, who was teaching out of Eugene, who did the orthopedic stuff kind of like Ben Benjamin, only I think he had sort of a bigger scope. And he did muscle energy technique, which I had been exposed to a little bit, and I got this initial impression that it was super complicated, like kind of like rocket science, and like it would be really hard to ever be any good at it. And this guy taught it definitely in the spirit of, this is not hard, it's not rocket science. You can do it, anybody can do it, it's not that big of a deal. And I started to take classes from him, and I got it. It's like, wow, I'm starting to feel like I understand more about alignment and sort of I understood more about the skeleton. And for the first time, I started to feel like I'm starting to understand stuff about the spine, and that was super exciting because I think the spine initially, like when I was first studying massage, the spine felt like, oh, it's this mysterious thing that chiropractors work on, and like how do you know if your C3 is out, and all that kind of stuff felt like really beyond me. So all of a sudden I was starting to learn stuff about the spine and feel like I can work on the spine and I can straighten out the spine. And that was super exciting. So it's kind of like my second big wave of excitement, sort of like orthopedic treatment, massage, evaluation, then muscle energy technique, evaluation, treatment. Like there's a theme here. And somewhere in the back of my mind around that time, I could tell that there was something I was looking for, and the something had to do with I wish I could evaluate everything in the body the way that I feel like I can evaluate the skeleton. Essentially, I wish I could evaluate the soft tissues with the kind of clarity and precision that I feel like I'm starting to get a glimpse of with the skeleton. And I felt very clear, like I don't even have a very clear sense of what would that even look like. And then I started to study with Judith Aston, and I felt for the first time I was seeing someone who really worked that way with a kind of precision on soft tissues, and she could say this is how I do it. She could teach people how to do it. And that was kind of my third big wave of excitement. It's like, wow, this is now I feel like I may be getting to what I was really looking for all along. So that was pretty great. And I definitely think of her as the person who had the most profound impact on me. And at the same time, because of the kind of skeletal orientation that I had and the kind of orthopedic orientation I had, those things felt like, in some ways, they didn't fit in her world that way. At any rate, I felt like the way she thought was super different from the way that I thought. So I felt like I have a different orientation and sort of a different language. So right away I started to realize I would love to be able to take the principles that I'm learning from her and frame them in a way that feels like it's more kind of the common language of the field, whether that's the language of structural work or the language of osteopathic work or the language of clinical work, treatment work. I felt like that's what I was drawn to do. And I kind of started almost immediately when I started studying with her. I started kind of re-languaging the things that I was learning to say, well, how would I talk about some of what I'm getting here? And two things happened. One, I got better at talking about it in a way that felt like this is the way I would talk about it. And I started to realize that I had sort of a bias towards certain kinds of techniques and certain kinds of hand positions and stuff that felt more like me. Felt like, well, Judith Aston would do it like this, but I would do it like this. In Judith Aston's work, there are different sort of species of technique, and some species are sliding over the skin and they use lubrication and stuff, and other kinds of technique don't slide over the skin, and so they don't use lubrication, and they can be done through clothes and that sort of thing. And pretty quickly on, when I started to do that kind of work, I realized that the kind of technique where you didn't use lubrication and you didn't slide over the skin that was the kind of technique that seemed the most powerful and versatile and kind of fit me the best. And so I started, in a way, kind of specializing in that sort of technique, and exploring how much can I do with that kind of touch and that kind of technique. And I think in many ways that's what turned into MFB. And certain fundamental things or principles started to emerge, again, in the sense of me thinking, how do I think about this versus how does Judith Aston think about this? Because this is the body, and it has its own principles, and we're just trying to figure out what they are. So one thing was definitely really thinking a lot about and feel the quality of mobility or lack of mobility in the tissue. I'd say in many ways the number one thing I got from Judith Aston's work that flowed into what I do was the sense that the tissue had, the soft tissue and the skeleton for that matter, all had a directional bias. So things were being pulled in some direction, more or less, and that the more you could get things sort of poised in a neutral way so they didn't feel like they had a chronic pull in some direction, essentially the better off we were. I started to think more and more clearly about end feel and directionality. I think pretty early on I started to think more clearly about how you could work on the soft tissue from the outside, but you could also get a sense of stabilizing the tissue against a bone and kind of pull the bone through the soft tissue from the inside. And that sense of versatility of being able to work from the outside in or the inside out via the bone, that pretty quickly became a key element of how I was thinking about body work. Three years or so in, post Aston patterning, I started to feel for the first time like I was beginning to get a sense of being able to feel people's balance in weight bearing with a lot of clarity, and I started to realize that unlike Judith Aston, I had never been a particularly good visual evaluator, and so when I started to realize that I could evaluate people's balance with touch, it felt like there was this big window opening into here's how I could know things that I had sort of thought you would have to get through your eyes before. So it felt like this huge opening and this huge opportunity. So I began to really, really think about how much can I feel people's alignment patterns. And a whole world started, I thought it was a huge, huge change in my awareness, because I felt like there were details of people's alignment patterns, the ways that things, what's that word, counterbalanced each other, or the sense that one part of the body would feel like it was well supported and sort of held up, and another part of the body would feel like it was sinking and sort of heavier. All these subtle dimensions of pattern and alignment and support began to suddenly reveal themselves. And I felt like, wow, I'm starting to understand things about people's bodies that I never even had a clue about before. So that was pretty huge. And I think in some ways that feeling of palpatory evaluation in weight bearing really rounded out my sense that there's sort of a model here that I can embody and do and teach. Since then is that really, especially because of Lauren and Lauren's sort of broader exposure to different kinds of osteopathic work, I continued to get a clearer sense of how do these kinds of principles apply to the cranium and the dura, and how do these kinds of principles apply to the organs, and how can these principles apply to the nerves and the blood vessels, and that sort of thing. So really trying to generalize beyond the idea that soft tissue work is the musculoskeletal system and nothing else, and really thinking that soft tissue work is about everything, or sort of manipulative work or structural work or balancing work is about everything in the body. I feel like that's a story that's still in the process of being told, and something that I hope to only keep getting better at.
I came to bodywork in 1994, in my mid-20s. I was looking for a job, and I knew that I had interest in working with people with HIV. And there was an organization in Seattle that brought you into an AIDS hospice here and coordinated massage volunteers. And I called them up and I said, "Hey, I want to volunteer." And they said, "Great, are you licensed?" And I said, "No." And they said, "Are you a student?" And I said, "No, but I can work on that." So it was one of the things, not the only thing, but it was one of the things that got me, the primary thing that got me interested in learning about massage. And gosh, as soon as I stepped into that door of learning about anatomy and manual techniques and healing, it really just opened and opened and opened and opened, and continues to open for me now, 20 years later. Still thinking about how much I'm learning with my clients and with students pretty much every day, every month. My initial training had a pretty strong anatomical focus to it, and sort of a structural, deep tissue kind of focus to it, which I really enjoyed and felt the effects of, the positive effects of in my own body, and enjoyed learning to work that way. And some of my initial continuing education was a deepening of that sort of deep tissue and structural alignment oriented work. And within a year after graduating, I also was introduced to craniosacral work, which completely enthralled me. So I had through my career a kind of dual track in many ways of the sort of structural oriented work that typically has a lot more vigor to it, and then the very light touch, motility based cranial work. And I carried on learning in those two tracks for a good 7-8 years, something like that, and kind of deepening my skills and my understanding, both through continued study, but also assisting in classes. So I'm a big one for repetition. So becoming people's assistant was a way for me to deepen my skills, and it's a great learning experience, because all of a sudden I had 18 people taking the class to sort of assess and palpate, and we had all these bodies to work on right away. So it's a really quick learning experience. I was also doing the same thing, teaching at massage school through this time. So I feel like my early years in practice, it was a lot of just sort of full-on immersion and study, both as a student and as a young teacher. I came to a place about in the early aughts where I felt like my cranial understanding and my sort of interest in the osteopathic method, working with craniosacral work and very process-oriented work, was at a certain level, and my structural work was not quite up to par, my anatomical understanding, all that. And my husband Richard gave me Tom Meyer's Body Cubed essays about functional anatomy. And I didn't get very far into Tom's book Tom's writing and thoughts about functional anatomy before I said, okay, I'm going to go study with this guy. So I rearranged my life a bit and got myself into the KMI structural integration training with Tom Myers. And that really shifted things for me. It was a little bit of a surprise to find out that it was in fact a structural integration certification program that I was in. I just leapt in, and I was about halfway through when I realized, like, oh, this is like Rolfing. It'd be like a Rolfer when I'm done. And that was such an interesting mind game for me, because I think like many people, I had created a mental construct where light touch cranial work lived on one end of a spectrum, and vigorous deep tissue work and structural integration, certainly Rolfing has such a reputation for really vigorous, sometimes painful work, that was either end of the spectrum, and it's really a false dichotomy. And over the next year or two, I got to learn how false that dichotomy was, because I was assisting in the cranial certification concurrently with taking Tom's training. And sometimes, very often through the year, I'd literally be in a 2-week time with Tom learning about structural integration, and I'd fly home, and the very next day I'd be in the cranial classroom, where we're back to 5 grams of pressure and following the body rather than directing it. So I really got this kind of a grad school education in what I came to understand was kind of osteopathic principles, and a real kind of crucible experience about what is the nature of intervention, what's my role as a provider, am I a witness to the healing process that's already occurring in the body, am I assisting it actively, if so, to what degree and in what ways, how much do I call forth from the client about their own active engagement in that process. So very interesting to kind of put side by side a typical cranial approach and a typical structural integration approach. I feel very grateful to Tom Myers that part of what I got from him really went beyond structural integration per se, but was very much the space and the time in his classroom to engage all those questions, and an intellectual construct of principles of the body, principles of anatomy, and ways of thinking about it that were beyond a single modality. And so I got a construct from him that really allowed me to create sort of a larger matrix in which to fit structural integration, the musculoskeletal, myofascial component, and craniosacral work, thinking about the cranium and the spine and the central nervous system, the visceral work that I had been studying and continued to study afterwards, and just as the body is one whole where all these different systems are intermeshed without any challenge necessarily, I got a construct from him that allowed me to understand it. It was a big enough basket where everybody got to be inside, and I didn't have to pick or choose. And that's a piece as a teacher now that I try to pass on. I try to pay that part forward. So sort of having a larger construct by about 2004, 2005, deepening my study with both another round of visceral training as well as learning neural manipulation. All of those seemingly disparate methods started to establish a synthesis, and really having conversations with Richard, and just a long, winding and sometimes rigorous and mostly curious conversations back and forth about our understanding, our sort of what's our best understanding about how the body's functioning, how does gravity play a role, how do we understand interventions and light force or not light force, all those things. We got to kind of just work all that through and come to a synthesis. And parallel to all of this was a process for me where I shifted out of a focus in my practice on working with people in hospice and at the end stage of their life. And when I had my son, I shifted into a deeper involvement with babies and the midwifery community, the natural birth community, and I started working a lot more with kids. So that was sort of parallel to this whole process of education. So part of my exploration throughout all this time was also what's it like working with all these ideas on big grown-up people, and what's it like applying all these ideas and work with young people, infants, newborns. My work continues to sort of circle around those same questions. What's the best intervention? How do I sequence interventions into a treatment plan? How do I know when I'm done? How do I know when the work that I've done has been effective and I can move on to something else? All those kinds of questions continue to orient me in my work, and 20 years in, I'm as interested as ever about learning about the body, learning about anatomy. Currently, for me right now, I feel like arteries and the blood vessels are one of the things that are sort of fascinating to me, and it's a new terrain for me to fill in the map, the anatomical map. I feel like the arterial system is the new kid on the block for me. It's a rich career that I'm so grateful that I really kind of fell into at the beginning, but have been so enriched by, and it's brought me so much, and I love giving back both to my clients and students. That's me.
So Lauren, given all the different kinds of work that you've studied and been associated with, now what kind of force or pressure do you use in the work that you do?
That's such a good question, and it's I'm glad you asked. It's such a good question. It's absolutely a question that we get in class, and I get from sometimes from parents, particularly if I'm working with their children and newborns, working with babies. And it's an interesting question to me, because I think in the community of bodywork techniques, we tend to kind of divide them by how much pressure they have. And to me, it is, I'm not thinking, the amount of pressure I use isn't a leading factor for how I'm deciding to do what I do. What the leading factors have much more to do with what's the nature of the restriction that I'm feeling in the body, the nature of the imbalance that I'm feeling in the body. And a kind of shorthand answer that is absolutely true, but maybe a little unsatisfying to someone who's curious, is I use just enough pressure to meet the restriction. So there isn't a constant level of pressure. I don't say I only work at 5 grams of pressure. That's sort of typical cranial light touch work, and I don't typically always have my elbow in and leaning full force body. Instead, what I'm doing is engaging the tissue and meeting a restriction. And what I've learned through these various methods is that in order for that restriction to change, I need to meet the degree of force that the restriction has in it, in a way. So some restrictions are more significant than others, And what I need to do is meet the level of force of this very restriction. And the way that I can best do that is to sort of start light and gently increase my pressure until I start to feel the tissue give. Which is, I need to pay attention in the moment to moment, as I'm applying an intervention. I need to continue to pay attention and continue to work with what you and I in our classes talk about as receptive touch. So I'm imparting into the tissue, but I'm doing so in such a way that I can still, my tool, my hand, at one in the same time as I'm applying force, I'm still able to feel and perceive back from the person's body, the tissue. If I were to just ramp up to a lot of force and just apply with a lot of speed and a lot of force together, I might miss layers or sort of moderate levels of restrictions and actually not treat them. I'd sort of snowplow them forward but not actually release them. Or you sort of wind up snowplowing everything together and then trying to move everything with a lot of force, which is hard on my body. Now that I'm 20 years in, my body's kind of tired of doing that kind of work. And because I want to keep working for another 20, 30 years yet. It's also more challenging for the client to receive in a sensory way. I think vigor, when clients come in and they say, oh, I really want to feel that change, and they're sort of hungry for a kind of sensory experience, often the way they ask for that is, I want a lot of deep pressure. You can go as hard as you want. So they are they're asking for it through the word pressure, but I think really what they're hungry for is sensation. And there's more ways than pressure to provide them sensation. And one of those is engaging client movement. That's a big one. So I can use a little bit of force and then they move their body. That doubles or sometimes triples the force on the restriction without a lot of effort. And another way is bringing people into a new level of awareness of their sort of internal state, both during our assessment and before and after the intervention, such that we start to give them new vocabulary for how to feel their body, feel where things are in their body, and how the mobility feels inside their body. How much pressure do I use has this really interesting backdrop to it that has to do with the nature of the intervention you want to use and what you're perceiving and what you hope the client perceives, all of that wrapped up together. So Richard, given all the different trainings that you've had and the study that you've done, at this point in your career, how do you think about the pressure that you use with clients?
One of the things I would say about what I'm up to now is that I think pretty uniformly about this notion of motion barriers, or sort of restrictions equal motion barriers, and our job is to move through them. So a tissue release or an improvement in mobility is moving the tissue through a barrier. That's one piece of things, and then there's this other piece of things that's the directionality. It's not just getting things to move, it's moving things toward balance. So like in some ways, what I just said, it's like the whole deal. It's what I'm trying to do. And then once you accept that, where you are is in this place where you say, well, if it's working, if the tissue is moving, if I'm getting the change that I want to get, then the amount of force that I'm using is appropriate. One of the things I really notice now, and I honestly can say I don't know why this is true, but I notice I'm not getting the response that I want to get to be producing the kind of change that I want to get. And so that and then I start experimenting, like, am I working too hard? Do I need to lighten up? Do I need to work harder to sort of get through that barrier? So sometimes I feel like I'm really experimenting. But the bottom line is that when you're coming up to a barrier and saying, okay, here I am at the barrier, I'm now going to move that tissue through the barrier, the force that it takes to do that is the appropriate force. I think in the grand scheme of things, I'm a sort of in-betweener. Like, I know there are people who definitely work harder than me, and I know there are definitely people who work lighter than me, and I feel like I'm sort of in between.
Can you talk a little bit more about direction? Because you mentioned you're not only freeing the tissue, but you're taking it towards a direction of balance, I think you said.
Yeah.
What do you mean by that?
So for me, I really feel like one of the fundamental divisions in the bodywork world, maybe the most fundamental division in the sort of tissue manipulation world, is the division between people who are working on tissue in such a way so that their fundamental goal is, I suppose most commonly, just to get something to relax or be softer, and often closely associated with that is to reduce pain in a kind of turning trigger points off kind of way. That's one big class of people in the bodywork world. And then there's people who are fundamentally oriented to directionality, which is, to me, essentially the same thing as saying that you're oriented to balance or improved alignment or improved posture, those kinds of things. So for me, I was lucky enough to go through this funny sequence of development in learning about bodywork where I first got exposed to, oh, here's balance as in balance range of motion in a joint. And then here's balance as in the vertebrae are all pointing in the right direction, to here's balance as in all the tissues in the body are kind of properly organized to allow the person to be in the shape that is sort of their best shape. And I think that was the essence of what Ida Rolf was bringing to the bodywork world, this notion that there was a sense of balance in shape, balance in movement, and that somehow was an expression of how all the tissues in the body were organized. My desire in being engaged in the bodywork world is as much as possible to express that sense of here's how to feel balance, here's how to improve balance. And so directionality, to get back to what you asked me, directionality is about balance, about helping all the structures in the body move toward balance. So one thing I would love to hear you talk about is where the whole notion of directionality fits in your work.
Really, directionality first kind of appears in our thinking when we're thinking about alignment, and when people are brought out of alignment by either habit or mechanical trauma or gravity. we tend to find tissue restrictions, restrictions of mobility, and those restrictions are not just a lack of movement in an area, but it's lack of movement in a particular direction. So you can imagine if it's a postural habit, say I'm accustomed to sort of slumping over to find the armrest in my chair, I'm settling my rib cage to the left and down, and there's a pull in the tissue and around the rib cage and the organs that's associated with that can then create a restriction. And that restriction would have a sort of a vector to it. Or say I'm in a car accident and the car is hit at the right front fender, and that has a vector, the forces that go through my fascial body and all the joints and again the organs. There's a particular vector to that insult to the body that in some ways you could say the vector leaves its trace in the tissue. It leaves sort of an imprint in the tissue. So when I'm assessing restrictions, part of what I'm looking for is what's the directionality of that restriction. So directionality comes into my awareness as part of my assessment process. And it's important to assess it because it then gives me the option of knowing which direction to free up the tissue. Because to be effective in my intervention, my treatment of the tissue of the body, one way of being efficient with that is if I'm aware of the vector, then I can treat in that same plane, that same direction, and I don't have to kind of treat it every sort of which way and hope that I get there at some point, right? So assessing directionality makes my work very efficient. It also then gives me the option of, do I want to treat the system in a way that goes with the vector of the restriction or kind of against that direction? And that brings us to ideas that are very much central to osteopathic methods and terms that people might have heard: indirect and direct work. So indirect work, by definition, is work that takes the tissue or the structure, the segment, in the same direction as the restriction. Direct work takes it in the opposite, back towards neutral, back towards balance, directly. And people tend to the words float around in the manual community, direct and indirect, and in a lot of ways they've sort of been merged with this idea of forcefulness. And there's sort of become an idea that indirect work is only light touch work, so craniosacral often is thought of as the 5 grams of pressure, that's all indirect, and light touch and gentle. And at the other end of a forcefulness spectrum, maybe we might have structural integration, Rolfing, Hellerwerk, KMI, and that's very forceful and direct. And it's useful to appreciate that indirect and direct merely speaks to what direction is the tissue wanting to go and which direction takes the system back to neutral. Mm-hmm. How much force I apply is up for grabs, is another piece. So when I work with students who have a lot of cranial background, they're sometimes surprised to learn that several of the sort of routine interventions that they use with clients are direct interventions. The temporal ear pull is a direct decompression along that suture. But they don't think of it that way because the force is very gentle. Let's see. The one other thing that I really want to communicate about directionality that I think is actually kind of really exciting is that they both work. Mm-hmm. Is that indirect methods work and direct methods work. And to me, so that begs the question of, well, when would I use one versus another? And that often, to me, relies on the state of the client. I think it is true to say that indirect work tends to be easier on the nervous system, the autonomic nervous system. It's less stimulating, and direct intervention tends to be a little more challenging to the system. So depending on how recent the person's trauma is, or how much inflammation they might have actively going on, sometimes it's just a personal preference. We all have clients who just really want the vigor and that sort of kind of a well-met pressure in their system. That feels very kind of like satisfying in a sort of a belly kind of a way. And there's other people that their nervous system or their personal taste, that would be overwhelming, and they want something that is softer and gentler to them in a sensory way. And what I like about our work and the way that we have sort of a focus on assessment and then efficiency is that if I know I'm in the direction of the restriction, it's really up to me and the client to figure out what's the best pressure that's most satisfying and most effective. And I can use a lot or a little force to just sort of, to make it kind of the just right amount for each person.
Mm-hmm. So, and you could do direct or indirect as needed or wanted. It's sort of your call.
Yes. Indirect or direct, and in fact I sort of pendulum swing. I go through kind of phases where my work tends more to be indirect for a little while, and then it switches back to be more direct for a while. And sometimes that can be confusing to people, that both could be effective. And the way that it really makes sense to me is that when I've got, say, two structures or an interface between one kind of tissue and the next kind of tissue, and what's happened is they're kind of stuck and not moving in relation to each other, what I need to do is initiate and establish some movement. So whether I take it towards the restriction or out of the restriction, it's still sort of just opening up the door. And that happens during my treatment. And then the client goes forth and lives with their body and breathes with their body and moves with their body and stands and stretches and walks with their body. And all of that continues the process of freeing up the tissue from my one intervention in the session room. It's sort of exciting to see how much change can happen when you're right in close to the restriction and then letting the body kind of take it from there.